screen. Let's put it down. Share screen. Host disabled participant to share screen. Can you allow me to share screen?
Okay, Dr. Rahim, can you please allow Dr. Fassier to be a co-host so that he can share the screen, please?
We can share now.
Okay.
Nice. We see the screen well right now.
Do you see it now?
Yes, we see it very well now.
Okay, excellent. So this is, first of all, thank you for the invitation to share my experience with you. And I have to declare, first of all, that I have some relationships with Pega Medical, who provides the Fassier rod, as you can imagine. And let's go briefly to history. It's very important, particularly because we're in Cairo tonight, because the first case of OI was found in an Egyptian mummy from Beni Hassan. And you can see that 1 millennium before Christ. And it's with the work of Gray, who was a British radiologist, who was able to x-ray a mummy that was thought to be a mummy of an animal because it was a very small. And in fact, it was, as you can see, there is a bowed bone like OI. And this is the reconstituted the skull of this mummy. So thanks to you guys, the OI history started long ago. Briefly, the legend of Ivar Benlos, who is a Scandinavian, and Benlos means in fact bone loss because he didn't have much bones, and he was carried to the battlefield on a shield. Now, you may remember some of these names, but I just want to draw your attention on the last line. You have to wait until 1980 to have to understand exactly the structure of the collagen and the role of collagen in osteogenesis imperfecta. So this is briefly the past. Is this the past? No, it's not the past. These are patients that I've had to treat not in the last few months, but in my last few years. So therefore, what is osteogenesis imperfecta? And the classic used to be, it's a collagen disorder caused by a mutation in the collagen genes, divided in 4 types and with no medical treatment. But probably every one of us know that tonight, none of these phrases still work. So what is OI? OI is a group of hereditary disorders, most often due to an anomaly of collagen, most often, but not exclusively, and characterized by the famous triad, bone fragility, blue scurry, and deafness, and other features, clinical features, such as a short stature, triangular face, DI, dentinogenesis imperfecta, etc. The diagnosis of OI, unfortunately, there is no blood test to do that. With blood, you're going to be able to do some genetic studies, but the diagnosis of OI is purely clinical and radiological. Therefore, you have also to eliminate what is not OI, because not all bone fragilities are OI. And at birth, you have to eliminate hypophosphatasia. And basically, it's not we, orthopedic surgeons, who do so. These are the pediatricians and neonatologists. Where our role is more important is with toddlers, because the diagnosis with child abuse is sometimes difficult. You have to understand that the context is different. The type of fracture, diaphyseal than metaphyseal. And this is the reason why we provide all our patients with an ID card that states that this patient is affected with osteogenesis imperfecta. Therefore, if the patient has to consult in an emergency department where the patient is not known, they're going to be able to demonstrate that they have fragile bones. Finally, in adolescence, you have to rule out juvenile idiopathic osteoporosis, but again, it's also spine fractures rather than long bones fractures. The classification of OI remains the same since Silence in Australia described it in '79. But with Dr. Glorieux, who is my colleague, a geneticist at the Shriners Hospital, we started publishing cases since 2000, and this has quite modified the overview of OI. What is important to realize is that here you have a normal structure for a collagen molecule. And you realize that in OI type 1, the structure seems to be normal. And in fact, it's normal, but its production is insufficient. And basically, you have half of the collagen you need. So it's a quantitative defect. It's OI type 1. It's the reason why these patients have a normal size, but have brittle bones. And in type 3 to 4, the collagen structure is abnormal. So in terms of genetics, I'm gonna stop there, and you're gonna realize that 86% of OI cases are related to collagen problems, except for OI type 5. All the others are autosomal. Just to illustrate what a type 5 is, type 5 are easy to recognize because the patients develop huge calluses looking like bone tumors. They have an progressive ossification of the anterior osseous membrane. Therefore, they lose pronation and supination quickly in the first years of life, and they have also dislocated radial heads. The clinical aspects of OI, I'm going to go through fractures, deformations, and briefly other systems. Fractures, the most important to remember is they heal within a normal time frame. Therefore, it's not only necessary, but it's ridiculous to immobilize these patients longer than a normal bone, because the bone that is formed is abnormal, but the delay to heal is normal. And then, therefore, you have to avoid this vicious circle, bone fragility leading to fractures, immobilization leading to osteoporosis, which adds on bone fragility. The fractures diminish after puberty and re-augment after menopause, particularly in the spine. They lead to pseudarthrosis, and this was up to 20% before the use of biphosphonates. It's now much more. Malunion, obviously, and typical of Osteogensis imperfecta, or the avulsion fracture, the olecranon, or the tibial tubercle, but the treatment is no different than in a normal bone. The mobilization for OI fractures has to be as light as possible and comfortable. This patient will spend months and months in different immobilization due to multiple fractures. And we encourage our families to get a training with our orthopedic technicians to know how to immobilize a baby, and etc. So we offer this type of teaching in our hospital. Now, always necessary? The answer is no. And in fact, you have to be worried if the limb is deformed, if the pain is around the hip joint, because it's difficult to diagnose a femoral neck fracture, and if also there is an acute back pain after a fall. It's pain to our families, this frontal femur fracture plate just below the plate. And you know what the surgeon did? A longer plate. So what's going to happen next? It's going to break again under the plate. The use of plates and screws is not recommended in OI as a treatment of long bone fractures. Now, some people say we could not use plate because the fixation in of the screws in the bone is not strong. but now it's longer true. But it creates a stress riser, and this has been published by Ken Noonan not long ago. And look at these x-rays here. This patient had a fracture, the femur was fixed with a plate, but compare the size of the medial cortex on the normal side and the plated side. You can see that there is a bone resorption that is quite significant. Therefore, the solution for a long bone fracture is not a longer plate. The difference in growth. That is anteromedial, because most of the muscles are posterolateral, and same for the femur that deforms anterolateral, because the hamstring, the more resistant structure to growth, is posteromedial. Obviously, when you have a bone that is not straight, it's going to break at the apex of the deformity, and this leads to repeated fractures. Upper limb deformities, we have been able to prove with Dr. Amako, who was a Japanese fellow with us, that not only the deformity was decreasing self-care and mobility function, but also grip strength. We'll come back at the end of my talk on the upper limb deformities. Coxa-vara is also a problem. I will say a few words also at the end of this talk. Protrusio acetabuli, a very difficult complication of OI. About 60% of type 3 OI develop protrusio acetabuli, and one of their major problems, as you see, this CT scan is not deformed. It is natural. There is almost no place in the middle for all the pelvic structures. These patients present with tepation and abdominal pain, and it's a challenging problem because there is no surgical solution for protrusio acetabuli as we speak. More difficult, again, to treat is the BI, basilar invagination, where the dens enters the foramen magnum because of the progressive deformity of the skull. The classic treatment is a fusion from the occiput to the C-spine and then a transoral resection of the dens. Not all patients can sustain such a long and difficult surgery. Finally, spine. And if you look more carefully on the x-rays of the spine on the right-hand side, you can look at the L5-S1. They are very, very thin. And if you go higher up, the thick part is the disc. All the vertebrae are collapsed. Okay, this is a spine before biphosphonate treatment. Thanks to the medical treatment, we don't see this type of spines anymore. Scoliosis is very frequent, type 3, but you have to remember that the scoliosis increases with the body mass index, meaning with obesity, but an improvement in the bone mineral density reduces the scoliosis progression. Amongst the other systems that are affected with OI, you know, the teeth, the eye, and the metabolic has to be remembered because some of these patients seems to have a basal temperature a little higher than normal children. And therefore, when they are put to sleep, they do develop hyperthermia during surgery. It is not malignant hyperthermia. But if the anesthetist is not aware of that possibility, there is a risk of panic during the surgery due to that hyper temperature. The treatment is a team approach. And you can see that we have to start with the medical treatment, then we correct the deformities with the surgery, and the patients are taken into a rehab to regain their mobility and their independence. This is an occasion for me to introduce my team. As you can see on the right-hand side, genetics, Dr. Glorieux, whom I've been working with for 30 years, and Dr. Rauch now has taken over. And on the left-hand side, this is my picture, but has to be replaced with Dr. Hamdi, who has taken over the OI clinic. And by the way, Dr. Hamdi is an Egyptian-born orthopedic surgeon. And the next one is Dr. Jean Ouellet, who is our spine surgeon. For us, the patient and the family is the focus. But around the patient and the family, you have the local health care team, the first line team, with which the family is going to be dealing for every fracture. They also have a possibility to be referred to a reference center such as ours, but the family benefits as well from the help of associations and family support. For our side, we have medical meetings and journals that help us connecting to the medical knowledge, and as well, lots of OI associations and meetings, and it is where we are today. I pass quickly on the treatment schedule with the pamidronate because everybody knows it, and if you need it, you can write to me and we'll be happy to send it to you. What is important is to realize that with the medical treatment, you have an increase of all the components of the bone. The bone mineral content increases, the bone volume as well, and the bone mineral density as well. Unfortunately, the biphosphonates have also some potential side effects. And you can see this patient is 2 years post-osteotomy, and the osteotomy is still not completely healed. So we looked at this problem with Dr. Munz, who was a fellow with us, and we realized that compared to the pre-biphosphonate era, no PAM, the number of slow healing osteotomies is absolutely increased tremendously. This is one of the problems. Now, the biphosphonates, we have modified our approach since 2003, 2004, and we realized that the surgery can be done after 24 hours following the last dose. Why? Because not most, but all the medication that was in the bloodstream has been either fixed on the bone or eliminated through the bladder. But no treatment recommended for 4 months after surgery or clear radiological evidence of osteotomy healing. And this is very important to avoid too many delay osteotomy healing. Other potential side effects of biphosphonates, you have maybe heard of potential effect on growth. There is none. Potential on ONG, that stands for osteonecrosis of the jaw. This is a complication that was described by give to OI patients in OI patients. But we see this. When you stop giving biphosphonate during growth, you can see that after the last treatment line, that is here, the bone that is formed there is no longer protected. So this bone is more fragile. And this has been proven by Dr. Rauch, who did CT scans. It's called PQCT. And you can see a PQCT in the lines of treatment gives a trabecular BMD score that is reasonable. But if you wait and you do the PQCT after 18 months after the last pamidronate dose, you can see that most of the bone has been replaced by fat tissue. Therefore, we have seen a few complications of this with fractures happening through the last treatment zone at those. So the question is, should the medical treatment be stopped during growth? In fact, we have decided to get a compromise, and we give a pamidronate short protocol, which is basically half dose until growth is over. Obviously, we are working as well on new and future therapies. The denosumab, which is an anti-rank L, is another osteoclast inhibitor, and it seems to be working better on OI type 6 than the other types of OI. Now, the best would be to support and to promote osteoformation, meaning anabolic, but the PTH cannot be used in children because of risk of developing cancer. Bones grow straight. It reduces the risk of fracture. And if a fracture happens because the bone remains fragile, it prevents displacement of the bone ends. We have to go back to 1959 when Sawfield and Miller described the first paper on rodding, not only OI, but as well as hypophosphatemic rickets, etc. So they were the pioneers in using this type of surgery. Unfortunately, at that time, they did this type of surgery, which means remove completely the shaft of the bone from the bed, put it on the table, do a kind of shish kebab, and place it back into the leg, which means you are putting dead bone with a tremendous delay for bone healing. So therefore, this technique is not recommended anymore. Immediately following their work, Dubois and Bellet described the first telescopic rod that in '63. And because of the use of percutaneous surgery, we started using it because minimally invasive surgery is important. You avoid scars, you avoid pain, soft tissue trauma, and blood loss, obviously. But it's obviously technically more challenging. This is one of the slides of one of my patients done a few years back, and the type of result and scars you can get with such an approach. Nevertheless, we had complications with the telescopic rods. Some are unavoidable, such as a bent rod following a fracture, but all the others are avoidable when the rod migrates into the bumlets, such as in the middle slide, or the T part unscrews and get lost around the hip joint. This is extremely frustrating. Therefore, multiple surgeons try to modify the Dubois-Bellet rod. And the first one was Sherrard in UK, who described the Sheffield rod. The Sheffield rod is basically a Dubois-Bellet rod, but the T end is welded and not screwed. Finidor in Paris, Karbuski in Germany, Osno in Turkey, Cho in Korea, all modified the Dubois-Bellet rod. But because I was extremely frustrated in the years 1996, when we started dealing with many, many cases of OI, I was able to find another approach and develop the Fassier Duval rod. When rodding, when the child is ready to stand, there is no need to rod a child that doesn't walk, because with the biphosphonates, you can get stronger bone within weeks, and therefore there is no need to do a surgery on babies. We have a limit of about 20 degrees. This is purely empirical. We don't have any data to prove it, but it's somewhere between 20 and 30 degrees that you should operate. If the deformity progresses, if there is a repetition of fractures, and for us, it's 2 fractures of the same bone within the same year. And finally, patients who have functional limitation, who cannot stand and walk. Why? Because children with straight bones and rare fractures do not need rods. How many bones can be rodded at the same time? Ideally, I prefer to do it on one side a week or 2 later. Very easily, you can do both TBA It's more risky to do both femurs because there is a need probably of blood transfusion because it bleeds more. And it's difficult combination of lower and upper extremity rotting because of the setup. With what? You can regular rods, they're able everywhere. If you still have yards, that is 3.2 millimeter in diameter, which means that you need to have large bones to be able to use it. And finally, you can use a variant which is in rods. Here is an example of deal with deformity. It was 11 years old when he came to Montreal and had never able to stand. So she is really at the age when we like to do the surgery. In the pre-op clinic, we evaluate the deformity of the bones, the bone density, the bowing, and we plan where we're going to do our osteotomies. The surgery is done one side at a week, and as you can imagine, you have to plan in advance when you have such deformity such as this severe equinus, preferably will be solved by myself with shortening of the tibia rather than lengthening of the heel cord. I prefer shortening the tibia because the muscle remains in a normal tone rather than lengthening a muscle that you may simply lose strength completely. At the end of the second surgery, we take the molds for the braces while the patient is still asleep. It has several advantages because the child doesn't feel pain. The technician does feel the limitation of the range of motion. And basically, when the patient comes back to the clinic 3 weeks later, the braces are ready to be delivered. The patient, in the meantime, is immobilized with long leg braces or long leg cast. And as you can see on the top middle slide here, I take a piece of tape to avoid external rotation because the limbs have a tendency with stress to fall apart, and the patient after that would walk like Charlie Chaplin. When the patients arrive to the clinic, they are fitted with the long leg braces if they have never walked before, or short leg braces if they have already walked. They are referred to physio. They start using a tilt table. After the tilt table, they go to the K-walker. And as soon as the physiotherapist feels that the quadriceps are strong enough, we shorten the braces. We were able to publish our results, and briefly, you can just focus on the left-hand side here, the FAQ, which is the Functional Ambulation Questionnaire. 2 is a non-walker, and 6 is the number after which ambulation is possible. So as you can see that there is a significant progression. At the top, you have the scale. We have been able, therefore, to demonstrate that at 1 year post-initial FD routing, the improvement in ambulation, gross motor function, self-care, and mobility is beyond physiological expectation due to growth. And this gain persists up to 4 years or even more. When is a rod revision necessary? You have here this patient with the Dubobele that is growing. You see the patient a few years later, and you realize that we are close to the end, the telescoping. What should you do? Should you change the rod now or wait? And if we wait, this may happen, meaning there is no fracture because of the biphosphonate and the patient is doing well. So therefore, you have 2 options. First option, change the telescopic rod when it is at its maximum elongation capacity. it's planned event, so therefore it's not an emergency situation, but it may not be really necessary if the patient is doing well. Or you can wait until this happened, it fractures between the two nail ends. So this is an emergency procedure, but you know what? It is not that it's the most resistant part, which is the female rod. So therefore, my preference is to wait until there is a problem. I prefer not to operate patients. We have been able at the 29 to show our results on 27 had more than 10 years follow-up. 53 weddings with 30 revision, a percentage of 36%. 69 complications, most of them related to the implant. But more interestingly, amongst the 30 revisions, 53% were due to a femur fracture. So this is related to the disease itself. It is not a failure of the rod. The patient remains with fragile bone despite biphosphonate, and they can still break. And if they break, they bend the rod. And if you bend the rod, then you have to change it. But you realize that the surgery first revision F17 Dominican Republic wheelchair, as you can imagine, unable to stand, running with rush rods, and you can see him now. This is him walking, and he chose to go at the most difficult part of his path, and this patient is completely autonomous now back in his island. Beware of the size of the implant. Here is an example of the left-hand side of a rush rod put in 2004, way too big for the size of the bone. And look, in 2008, 4 years later, the bone has almost vanished around. It's called disappearing bone. Very difficult and challenging situation. Let's put an eye on special hip problems, and they are very attractive to me because I've been dealing with these problems for years. Special hip problem, is this patient having a coxavera, or is this a pseudo-coxavera? What can lead you to understand this is this. There is what I call the circle sign. You can see this image, and this image is due to the fact that the beam, X-ray beam, goes through almost perpendicular to the shaft is parallel to it, the proximal part is not. Therefore, if you do an osteotomy in this particular patient, you end up with this result. There is a normal neck shaft angle. It is not a coxavera. And how can you be sure of that? At the moment of you start surgery, you put a hip with the leg hanging, and therefore you're going to be able to have a better image of the proximal femur and look at the neck shaft angle. I have been able also to describe in the GPO a few years back the technique that is illustrated here, which I'm very pleased of using, and this gives this type of result. And you realize that there is a big deformity of the bone because the proximal fragment lateral cortex going to heal with the distal diaphysis, but this heals very nicely, and this gives very good result because you put tension on the abductor mechanism. Upper extremity running, a myth. The problem is purely cosmetic. As you can see, this patient. But what about this one? This patient has a type 5 OI, is unable to reach his mouth. Very difficult on both elbows. Why is less surgery happens to be done in upper extremities? About 10% of OI surgeries only. Is this because it's functionally acceptable, or is it because it's technically difficult? There is big nerves around the upper extremity, and there is a much higher risk of neurological complications in the upper extremity than we have in the lower extremities. And also, most of orthopods are more used to treat lower extremity than upper extremities. The indication for us, obviously, same as for the lower extremity for frequent fracture or increased deformity. But in addition, we have specific indication for upper extremities. The need to use crutches or any type of walking aid, difficulties in propelling wheelchairs, and more important, self-care. Therefore, these patients are always checked by our occupational therapist, and if they demonstrate that the patient has difficulties in one of these three domains, then we'll go for surgery. Some technical points. In the forearm, you cannot use the telescopic rods because of the shape of the bones. So we use K-wires, elastic nails or slim nails. And it's the principle of the sliding rods, meaning you have one rod that is inserted from the distal radius to the proximal radius, and the other one is inserted from the proximal ulna to the distal ulna. And during growth, the two K-wires migrate along each other. For the humerus, we have the possibility of antegrade rodding with K-wires, rush nails, or even telescopic nails. Retrograde rodding with K-wires such as an Eiffel Tower construct is possible. And personally, I prefer the telescopic rodding from the bottom up. This is something that I've not published yet, that we're working on that because it's much easier than antegrade, but we don't have long-term results, is the reason why we're still waiting. But we were able to publish the result of upper extremity rodding with Elizabeth Ashby, a fellow from UK, who spent a year with us. And she published two papers, one of the result of the functional result in upper extremity humerus and one with the forearm. And amazingly enough, our results demonstrate that humeral rodding leads to a very modest improvement in functional capabilities in children with OI. But forearm rodding leads to a significant improvement in functional ability in children with moderate OI. Why? Because we think, because of the reduced fracture risk, there is an increased confidence in the arm, you have an improved grip strength, and you increase the functional length of the arm, so you can reach more. For example, you can reach your bum for self-care. So I refer you to these papers that are interesting for that. Therefore, I would like to say shukran to all of you, and particularly to Dr. Hesham for his kind invitation to share my experience with you. And my little Enrique, as you can see here, is a patient who was thrilled because he is the drummer of a band, and he was unable to stand to sing. His surgery, now he sings standing. Thank you.
Thanks a lot, Professor Fassier. It's very fruitful and very beneficial lecture covering all aspects of medical and surgical tips and tricks. We are so happy for this interesting topic. And now we shift to Eva Pharma Company presentation for 3 minutes. And after it, we go into case-based discussion. I have a few cases I've sent to you before, Professor Fassier. We are going to discuss them with you. And then if you have any other case about some difficulties in retrieval or something like that after my presentation. Okay, sir?
Okay, no problem.
Okay, thanks a lot. To Andrew, could you please proceed to your presentation?
Hello, everyone.
May I say, okay, I'm sorry. I want to make an announcement. If the audience have any question, please write them in the chat box in the Zoom link downwards, and we shall discuss this question with Professor Fassier during the case-based discussion. Okay, proceed now to Andrew, please.
Good evening, Professor Francois and Dr. Hesham. Let me first introduce myself. I'm Abanoub. I'm Assistant Product Manager in Eva Pharma. I just want to share my screen, so please, Professor Francois, could you close the presentation?
I've put it down, but I need to keep it because I have a few more slides for the discussion. If I close this, I'm going to close the Zoom and I'll have to...
You can share, do just stop sharing and
Stop sharing.
Yes,
okay,
yes.
Done.
Okay, thanks a lot.
Our presentation today is about osteoarthritis. Our product is Acticola-C for treatment of osteoarthritis. It improves joint performance. Let me first share with you some prevalence and statistics of osteoarthritis. 34% of adults more than 65 years old suffers from osteoarthritis, and 14% of adults more than 25% suffers from symptomatic osteoarthritis, and it's a high percentage. Also, some risk factor of osteoarthritis. It's the most common risk factor of osteoarthritis, like genetics, age, gender, female more than female, mechanical injury, and obesity. Our product for treatment of osteoarthritis is a unique combination. First, it contains collagen hydrolysate from marine source, which is a most abundant component in the cartilage, and also rose hips, which play an important role in Acticola-C, as is anti-inflammatory effect, and finally vitamin C. Our collagen is from a marine source, which considered to be the safest source for obtaining collagen, and it has many advantages over other animal sources. First, it's free of zoonosis, high content of collagen, and finally, it's greater absorption due to its low molecular weight. And regarding rose hips, it's considered to be the extract from a fruit called rosa plant, and it has many benefits, but the most important for osteoarthritic patients, it has anti-inflammatory effect and arthritis helper, which decrease the pain that the patient feels. And the last component in Acticola-C is vitamin C. Vitamin C plays an important role in osteoarthritis, as it is required in the biosynthesis of collagen, and also vitamin C plays an important role as it has a physiological antioxidant. And vitamin C deficiency may risk for development of osteoarthritis. Also, regarding the daily intake of vitamin C, Acticola-C provide more than 60% of the daily required intake of vitamin C. Also, let me share with you is one of the trials that Acticola-C provide. This trial study design is made for more than 100 patients, majority female, 70% female, overweight. Most of them was above 50 years old. They were receiving collagen 5 gram and 500 milligram rose hips. It's done for 3 months. It was multi-center and observational. The conclusion that there is a synergistic effect when collagen and rose hips are administered together, as it shortening the time of effect from 12 weeks to 4 weeks. So the patient start to feel better after 4 weeks, not 12 weeks. It also reduced the intake of non-steroidal by 15%. Acticola-C has many advantages and many unique points other than the other collagen in the market, as it has excellent solubility, as it's from marine source. So it ensures the complete dose administration. It's halal, as it's from marine source, not bovine or other source. Eva Pharma and Emma, which trusted company with high quality of products. Actiquola-C in the market in 2 different packaging, 10 sachets which equal 130 and 30 sachets equals 330 for the whole month. The dose 1 sachet daily at least for 3 months. To sum it up, for Actiquola-C, Actiquola-C has a structure modifying effect as it contains collagen, the major component of the cartilage, and it also improves the quality of life as it reduces the joint pain and inflammation. Also, it reduces non-steroidal intake and shortens the time of effect occurrence to 4 weeks. As we said before, we have a combination between rosep and collagen and synergistic effect between them. And it has excellent solubility to ensure the complete dosage administration. And finally, it has an orange taste and sugar-free for better patient compliance. And it's sugar-free for any patient suffer from diabetes, so it will be fine with him if he take Actiquola-C. Thanks a lot for your time. Thanks, Dr. Hesham. Thanks, Professor Francois.
Thanks a lot, Dr. Abano, for your nice presentation. And now, can you please stop sharing your screen? Okay, we have 2 questions, Professor Fassier, before I share my presentation. The first question is when to stop giving bisphosphonate to osteogenesis imperfecta patients.
Can you repeat the question? I didn't get it, please.
Okay, the first question was when to stop giving the patient bisphosphonate. Is it will be given for life, or we're going to stop at some time?
You may have noticed that if we stop during growth, there is a problem because the bone continues and this bone is not protected. Therefore, we give the biphosphonate until the end of growth. When the growth is over, we stop. But then we follow them patients, and if the bone mineral density has a tendency to decrease, then we give few doses, but dose after dose. We don't give a constant treatment.
Okay. The second question is when to give the medication, before surgery or the surgery first?
We give the medication before surgery. The patients are treated immediately after birth, within the first 10 days of life. Therefore, they develop stronger bones, and if the bones are deformed, then we can treat them at the time they start standing or they are putting up to stand. So we give the medication first, then we correct the deformities, and then they go to rehab.
Okay, thanks a lot, sir, for answering this question. Now I'm going to share this few cases with you, sir, and I will ask for your remarks and comments on them. This is a case of male patient, 10 years old, with osteogenesis with fracture of the shaft of the femur, and the traditional way of fixing such fracture is to do shish kebab technique, putting elastic rod or rush pin retrograde from the fracture site, and while introducing it in a distal fragment where it meets the apex of the deformity, another osteotomy is done till it reaches the end of the bone. As we all know, the patient is put in hip spica, and this is what happens when the patient starts to grow. Bending occurs at the end of rush pin, which results in that the patient will be operated many times. And till the era of telescoping nail, which is the ideal treatment for osteogenesis imperfecta, where telescoping occurs and no more need for multiple surgery like rods. I like this description in the chapter you write, say that the bone in the osteogenesis imperfecta is rib-shaped. It is not the regular bone or triangular and medulla, but it is flattened like ribs. So the accurate dimension of the diameter and the precise measuring of it is quite difficult. In this case of female patient, 5 years old with osteogenesis imperfecta, we see here the presence of this deformity in coxavara on the right side, and the sign you mentioned here is a crescent sign here. And also in the lateral view, we have this severe flexion deformity. So in treating osteogenesis imperfecta, the coronal plane is not only deformity, but the femur. There's always this flexion deformity that should be kept in mind during planning for osteotomy. This case, we treated it with telescoping nail. We started doing it just a few months before COVID lockdown in our institute in Asyut. And we did subtrochanteric valgus osteotomy here and another osteotomy Mitcha. Intraoperative, the nail was centralized well. But during follow-up, we had this X-ray with dislodgement of the female threads from the greater trochanter. And we asked ourselves what went wrong? What was what happened during the application of the telescopic nail? Until I searched for this and found this interesting book and the chapter written by Professor Fassier. It was really concise chapter with a lot of tips and tricks summarizing the whole experience of Professor Fassier in this amazing book. And I found the technique that Professor described in this lecture, that when having subtrochanteric valgus osteotomy in coxa vara, there's a lot of stresses in a very short fragment. So reaming at the lateral cortex and putting these key wires, bypassing the femoral hypophysis and doing circulage of tension band will help to keep the bone in alignment and compensate for the stresses on the proximal fragment till union case. Okay, this case of female patient 7 years old with osteogenesis imperfecta with history of multiple previous surgery of rodding, and now the patient is presented on the right side with coxa vara, atrophic non-union at the proximal femur, and labelless discrepancy about 7 centimeters. This is the clinical photos for the severe bowing of the leg and femur, and the labelless discrepancy on the right side. And we use the technique described by Professor Fassier for measuring the coxa vara by letting the leg hanging outside the table to take true and true stereo view for the proximal figure and measuring the coxa vara. We started by telescoping nail for the tibia by doing 3 osteotomies under tourniquet. And for the femur, we excised part from the atrophic part and doing this technique with key wires and circulage. And with, at the end of the surgery, we have this intraoperative X-ray. What's your comment, sir, about this case?
It's difficult for me to analyze the with a pair of glasses, the proximal aspect of the femur post-op. I would say that I'm not sure that the cerclage are around the shaft, are they? The cerclage
around the shaft, yes.
Of the shaft. So
we don't have these cables like the original technique, but I use this circulage instead.
Okay, so looks that you've improved the angle. It's not perfect, but it's improved. So I would say that it looks better than it was. Now, will it heal? Because it's a very atrophic non-union. And I may have added some bone grafting as well because of the quality of the bone. Otherwise, obviously, is this patient a walker or just a sitter?
And when he was presented, he had too many multiple surgeries, so he was not walking. He was really chair dependent.
Okay, so if the patient is not walking, having a coxa vara is very tolerable. You can tolerate much more than on a walking patient. So I would say that you have improved. You have given strength and solidity to the bone segments, and probably help this patient, having a better life in the sitting position.
Okay. My question is, in this case, when we have a limb length discrepancy in a walker child, what are the options for lengthening the bone of osteogenesis imperfecta? as we all know, for example, Elizarov lengthening, I don't think the guide wires or channels were involved in osteoporotic bone. What are the implants or the techniques that can we lengthen the osteogenesis imperfecta and limb discrepancy in a walking child?
That's a very good question. A very good question, because in fact it's a surgical challenge. Therefore, when I see a patient that is young enough, I don't hesitate to do an epiphysiodesis on the other side, not to run behind a discrepancy that's going to get greater over time. I have done a couple of lengthening in OI patients, simply at the request of the patient, because the patient were grown up, so they were adults, young adults, and they had no left, and the patient had 6 centimeters limb length discrepancy. I was able to lengthen his tibia with 2 osteotomies, one proximal, one distal, and after the lengthening, obviously I had to re-rod and protect the bone. Okay, now I think it's very challenging, and if the patient has already a rod in the femur, I would probably in the future go for a lengthening nail, because you add the protection of the bone at the same time you lengthen. So you have different types of nails, but the problem is the size. These nails are quite big, and I am not sure that they would fit in such a small femur.
Okay, I was asking, in case you were lengthening the tibia, sir, did you use Elizarov for lengthening?
I used Elizarov, yes.
Okay. Okay.
There is another team in UK that have been able to use Elizarov as well in a forearm in OI child. You can find that in the literature. The Sheffield team.
This is another case similar to the previous one, but there is no atrophy non-union in the femur, and there is no severe coxavara like the previous case, but when doing subtrochanteric valgus osteotomy that is near to the bone, I use also this technique to give some stability for the proximal fragment, and the scoping nail for the femur and the tibia was done in the same session. What's your remarks here about this case?
You have a tendency to cut your K wires too short. I prefer, do you see my my arrow?
Yes.
Okay, I would leave them until here at least, and then put 2 cerclages on this bone fragment, because you need really to have a stronger fixation for the to prevent the varus again. Okay, so the technique looks very good. I would simply leave the K wires here a little longer so that your fixation is going to be a little lower.
Okay.
Otherwise, looks very good to me.
Okay, thank you, sir. This case of male patient 7 years old with osteogenesis imperfecta and a very short stature. In this clinical X-ray photo, this is a 10 centimeter series. You can see how far the short the leg it is. And this, I thought in the X-ray, it is thick rush pin, but actually it was the thinnest key wire I have ever seen. And this one on the right side, there's too much difficult in retrieval because it was behind the cruciate ligament and severe deformity at the leg and the femur. The smallest diameter of the osteogenesis imperfecta telescopic nail available in our institute will not fit him. So we did osteotomy and putting another brush pin. We added supracondylar another crossing wire for the distal femur, and we added key wires crossing the ankle joint to fix the distal osteotomy. And this was the final clinical photo for the right side when it was evaluated, and show how much lengthening have been gained and correction of deformity. What's your remarks say about this case?
I would have done exactly the same, meaning when you see such a shortening and you have, you're too near the joint to correct, and you have absolutely no purchase on the distal fragment, I go through the joint. And time, because in the past, the Williams rod, for example, were used in the past, and some of them were left across the ankle joint. And with time, it migrates, and then the ankle can move a little bit. Doesn't move freely, obviously not, but you have restored the length and a much better look to the leg. And if this patient at one point, if the left leg is fixed, this patient might be able to stand.
Okay, thanks a lot, sir. And now this case of male patient, 22 years old, with osteogenesis imperfecta, had previous multiple surgeries before, and a very short stage. On X-ray, if you see it, you may suggest that doing ordinary nailing for the adult, for example, Rico nail or ordinary interlocking nail, antegrade, for example. But when seeing the patient clinically, he has his thigh was less than 20 centimeters. So the shortest nail and the narrowest nail will not be available for him. And he's skating mature, so the telescopic nail will not work properly for him. So we used the combination of intramedullary rodding with the locked blade on top. The intramedullary rodding will prevent the stress riser of the locked blade, and the locked blade will control the rotation. And we would hip spica as we treated him as if he was a child, because he's very short stature. What's your comments here about this case?
First of all, I'm a little surprised with the quality of the bones. They look extremely fragile. And this patient received lately some biphosphonates?
Unfortunately, this patient was not receiving this.
Okay, yeah, that's the reason why these bones look so poor. Now, in such a situation, I've already had this type of problems, and I was able to use a humeral nail, because the humeral nails are smaller than the femoral and tibial nails. But sometimes the company refuses that we use it in lower extremities.
Oh, yes.
And I had to send the x-rays to the company saying, tell me, what can I use instead of, and the answer was, here, you get your humeral nail. So I did it with humeral nails, and it worked very nicely because you can lock them as well. Now, your slide leads me to discuss a little bit the presence of plates in OI, the use of plates. I mentioned in my talk that plates are not good for fractures, but plates can be used in OI in association with IM rodding, as you did. Okay, and it is used. The promoter of this is Dr. Cho from Korea, who has demonstrated because some of these patients have subtrochanteric osteotomies or fractures that never heal, and he was able to make them heal, adding a locking plate, unicortical screws that more or less compresses the lateral cortex of the femur. And this is a very good adjunct to when you are, you cannot put a big nail inside, you put a small nail and then you add a plate. This is a very good solution.
Okay.
In OI, you have to have your brain lit up constantly, meaning you have to be able to have a plan A, a plan B, and if possible, a plan C.
Exactly, sir.
And be able to change in the middle of this surgery to a plan that you didn't think of before. Because sometimes the local condition of the bone leads to a bone that crushes, and sometimes, I've had to stop. There's nothing that's going to hold the bone. We put the patient in traction. And instead of trying to put more and more screws and metal, you leave the patient in traction, the femur is going to heal, and after you can go back and treat the patient.
Okay, thanks a lot, sir.
Don't forget the traction, skin traction, as we did in the very old times, can be used still nowadays.
Okay. The take-home message is that using the spinator, use the fracture rate. It can be given 48 hours before surgery, and post-operatively we should stop using the spinator for 4 months until union occurs, because osteoclast is needed for remodeling of the bone. The deformity of an osteogenesis is a 3D problem. The bone is rib-shaped, and the child needs more bone than metal. Don't use oversized nail on the expense of the more cortical thickness. We don't need to overread children before working age, and you should give a concentration of in the soft tissue tightness and shorten the bone of angulation beyond 60 degrees and the presence of the coxavara and the quinous deformity. The scope nail is a treatment of choice. Avoid oscillating through during doing osteotomy because it causes thermal injury to the ends of the bone and delay union. And comprehensive approach of medical surgery and post-operative rehabilitation is needed. Thank you.
Thank you. I couldn't say it better. You have just summarized my legacy, and just on one
Yeah.
thing.
Okay.
You treat a child, you don't treat an X-ray. Because
Exactly.
if you look at most of my patients, you look at their X-rays, they're going to all need some type of surgery. But if they are functional, they're able to walk, no pain, they don't break, why are you doing a surgery? Treat the patient, not the X-rays. You can add this one to your summary.
Okay, thanks a lot, sir. Now, if you have the rest of your presentation, sir, you can share with us about some case-based discussion.
Revision cases. I have 2 revision cases. Let's go back to my. Are we set? Do you see
Yes,
it?
it's,
Okay.
yes, we
So,
can see it here.
I have 2 examples, one simple and one more challenging. So the most simple one is this patient had surgery done several years before. As you can see that here on the right-hand side, you have a fracture of the ankle, and then therefore there is a malangulation. The proximal part of the nail has sunk into the diaphysis, and the patient ended up with a below the tip of the nail fracture with flexion of deformity. So it's relatively straightforward because you have to remove the implants, do an osteotomy at each level, and re-rod. So it's quite straightforward. And again, have a plan B, just in case the bone breaks, so etc. You have to have to be ready. And you can see that the post-op X-rays demonstrate that we have corrected completely the angulation here, the angulation there, and the nail now is in a better position proximally. So this is a very simple, straightforward. A little more.
I
Yes,
have
go
some
ahead.
question about this case. Sometimes during application, as you have mentioned in your books here, that there should be only one trial for the straits of the distal epiphysis to go through and not to do multiple trials. Sometimes if we put the straits and in intraoperative X-ray, there is malalignment or it is not completely central, we retrieve it and reinsert it again. We find some cases that it is not well fixed because there is a lot of trials. Would you put the scope nail and hold it with crossing wires, for example, and put him a spiker, or just remove and give him some rest to form some bone? Which is better to do?
I'm not sure I got your question exactly. So you mean that when the nail during the surgery is not particularly well positioned? During
Yes,
the
if we,
okay,
yes,
so
during the surgery.
I don't hesitate to do an extra osteotomy. I have never regretted to do an extra osteotomy to make it more central, both on AP and lateral. I have always regretted not to do it, because if you end up with a nail that is too anterior in the knee here, it may just cut through or bend. Same thing here. So really be at the tip of the trochanter, not too lateral because it's going to cut through, and too medial because it may cause a
Fracture, neck femur.
neck fracture. Yeah. Okay. No, I agree with you that you have to be extremely exigent on the position of the distal. Let me just say one thing that is difficult to teach. When I put my male nail here, I screw it until I feel the subchondral bone, the articular cartilage, okay? Because it's where you have resistance. If you leave it in the middle of the epiphysis, the bone is extremely fragile and the purchase is not good. So don't hesitate to go as far as possible. And you know what? You are in the middle of the knee. So even so you perforate, for example, the articular cartilage, it's not a weight-bearing zone. It's a non-weight-bearing zone. So you have no risk of damaging the knee, but you have a much better purchase for the male nail. So I think this is one of my tricks.
Okay, my another question is, during revision of the nail, if the scoping occurred and the female part is removed, the male part maybe it's quite deep inside the shaft of the femur. What are the tips and tricks for retrieval of this male part which is inside the bone?
Okay, so if the male part is inside the bone and the bone is not deformed, straight, why do you want to change it? I leave it. It has happened to me to change the female rod and put the female rod over the male that was left in place. If the male is in a good position, I would not change it. But obviously, if it's bent, if there is a fracture, then you have easy access. And I'll show you a tool in a second that we use for such cases.
Okay.
Okay. So let's go to the second case. It's a patient with the coxavara, and that was treated. And at the time, here you can see that the nail has migrated laterally. There is now a proximal femur deformity. It's not coxavara anymore because the varus is lower than the greater tract. So
yes.
What are the strategies here? The strategies, you have two options. The first option is you cut the femur at the level, at the apex of the deformity. Okay. For this, you need a Midas Rex. You know the Midas Rex? It's a saw that is able to cut the metal at any place in the body. So you cut it here. Okay. Then you put a K-wire inside the rod. And therefore, you have access to the axis, and you can ream here over to have access to the rod and to retrieve it. You can put the screwdriver in, but at the same time, you have to push on the distal part. So it's called the push-pull technique. It has to be done by the same person because it's a matter of brain. You can push and pull at the same time, but you cannot ask someone to push while you pull because two brains are going to end up in a disaster. Okay,
yes.
So
yes,
this works nicely and you can do so. The other option is to open, and in this case, the nail is superficial and you can see it here. Okay. With a rongeur, you can just remove a little bit of bone around and retract and remove your you move your female rod.
Female part. Okay.
Okay. Now, if the male rod is still in, you have this option of female retriever and this option of male retriever. The male retriever is basically a hollow tube that is like some of the pencils we use. You know, you have a little clip at the end.
To hold the male.
Exactly. So you lock it with the proximal thing, and then you can remove your. So if you need that, Pega has this type of tools, but you have to order them. Okay. In advance. So if you do a revision case, ask for the retrieval system.
Retrieval system. Okay.
Okay.
Thanks a lot.
So this is pre and post revision. You can see we have now a straight femur with just one osteotomy, and Nathan has not had to have his rod changed since. Voila.
Oh, thank you, sir, for your thoughtful lecture and remarks and comments on these cases. We are very grateful for your kindness, sir, and we hope we can meet live maybe later on or online again.
You know what? I hope at one point to go to Beni Hassan.
Yeah, I think it's an Asyut. Yes, Beni Hassan, I think it's an Asyut in our governorate.
Okay, I hope so, to be able to not only, I've never been to Egypt, so at one point I hope to have the opportunity before it's too late for me. And I will certainly pass by Beni Hassan to say hello to the first Egyptian in a while.
Okay, we will happy to have you here in Egypt, that's for sure, sir, and thank you again. And we hope all the audience enjoyed this lecture very much. Thank you a lot, sir.
Thank you all, and thank you for the organization. And I remain available should you have questions for OI patients.
We don't have any other question in the chat box, so I think everything was clear. And thanks a lot, sir. And we are recording this lecture, and once it's complete, we will put it. I will give you the links here for it, inshallah.
Take care.
Have a good night, sir.
Thank you.
Assalamu alaikum.